انت كل
Okay, so I resumed the recording. I did not start it since the beginning.
Very good.
امينه انت كل اللي بعتيهم بانلست ها؟ يعني انت اللينك انت بعتها ده بتاع بانلز.
كلهم داخلين بانل؟ لا، ما داخلين اتندي.
بس يعني
ما هو فيو فول اتندي لسه ما داخلين اتندي. اماني واميره وبسنت اشرف هدير نجاة منى ريهام.
انت بعت لهم اللينك عشان بعتيه في الاخر.
اتندي.
طب انا ابعتوا لي تاني، ابعتوا لي واتساب وانا هعمل دلوقتي.
into the email account assigned by the host. خليني ابعت invitation تاني.
Oh, it looks like some people are coming in now.
Yes.
Yes.
We're right on track.
Yes.
Copy invitation. Copy. And here we are. طيب انا هبعت لهم الطريقه الثانيه برضو عشان اللي عايز يجوين. يمكن عشان ما كانوش مسجلين نفس الايميل بيحاولوا يدخلوا من ايميلات مختلفه.
واحد تاني هبعت حالا دلوقتي تاني. اللينك اللي هو على الواتساب صح؟ اللي هم دخلوا بتاع الانفيتيشن.
Back in 30 seconds.
And then save all. And here we. أنا لقيت إن هما لازم يregister and we can registration required. Link to join. Copy invitation. Okay.
دكتور فادي ممكن تبتدي علشان دكتور ستيفن ما يتعطلش؟
ثواني بس أنا لا هبعت بالإيميل للناس كلها دلوقتي كلهم. Just a second, sir, and we will be on.
دكتور فادي؟ يلا.
ثواني.
We are very sorry for this technical delay. We appreciate you waiting for us to start.
Yeah, it's a pity. I hope people are able to get the message of the new link.
We'll send them the link right away.
أنا بعت لك لينك يا فادي.
ثواني حاضر. أنا بس عشان ببعت 501 emails. Those are the attendees so far, so it's gonna take a second.
Yeah.
Even the phone is like can't handle this much data. Okay.
You have to be careful if you send out so many at once. Sometimes the internet stops that. So do it in waves that will get past the firewalls and all that.
Yeah. Okay, just a few seconds so the emails will be sent to everyone. So in the meantime, we would love to welcome you to the Arab world. We have, yes, if you can guess, from the 500 people attending tonight, we have people attending from Egypt, like the majority. We have people from Libya, Sudan, Emirates, Saudi Arabia, Somalia, and the Gulf world, almost all of them, Morocco, Algeria, is everywhere. And even people staying in the States and Europe who are actually Arabic. And so you have, it's safe to say you're talking to the whole world today. It's going to be something global and something unheard of. So we are very excited to let that happen.
Oh yeah, it's a major event, and you know, you should let the newsletter, the ACBS newsletter, know about this. I think people around the world would be interested in your progress, and so I hope this contributes.
We hope so.
And we can wait a few, you know, as far as my schedule, as I say, sort of, you know, the illness I'm dealing with, we can take the time. So if it takes,
Yes,
you know,
yes.
5 or 10 minutes to get the people in, don't worry about it. It'll be fine on the other end.
I really appreciate your journey, Dr. Stephen, because you did a lot for the humanity. Before ACT, it was all about CBT, and CBT always become impaired at some point in the progress of the patient. But ACT is fluent, and we cannot be at a corner at any point of time. This is very good. I really appreciate what you did to the whole world.
Well, thank you for that. You know, I'm working, and we're going to talk about it from these questions with my colleagues in more traditional CBT, and, you know, ACT is broadly part of that tradition. But I think what we're going to see is that classic CBT, which I do think had some limits and also some cultural limits, some of these, it didn't land as well, I think. If, as we get in a more process-based direction, we can take down these needless walls and work together and take what's really helpful and what fits. So I'll talk some about that. And I, you know, my prediction is 5 years from now, 10 years from now, talking in terms of CBT and so forth will be way down. Talking in terms of ACT in terms of a narrow sense will also be down. What will be up is these processes we've been focused on in ACT, and with many new ways of moving them, and some additional processes, and I can talk about that some. So I think we're part of something that's progressive and is going to change the world in a positive way if we do it right.
Yes, thank you. Can I translate, please?
Oh, sure. If people are listening, are they already? I guess we have 40 people so far.
Yes, yes. دكتور ستيفن بيتكلم على ان هو انا كنت بشكره على الجيرني اللي قام بيها لحد دلوقتي في انه يخدم البشريه بسبب الاكت، وكان ده بالمقارنه بالسي بي تي. فهو كان بيقول ان السي بي تي جه عليه وقت وفعلا عطل، والاكت ابتدى ياخد المجال علشان كان culturally fit مع، يعني بيتوافق مع الثقافات المختلفه. ولكن هو شايف ان بعد 10 سنين من دلوقتي ممكن كمان الاكت يعطل ويبتدي البروسيس بيزد ثيرابي او العلاج المبني على العمليات المعرفيه هو اللي ياخد الابر هاند، لانه مور برود سبيكترم، يعني واسع المجال اكتر وبيغطي حاجات كتير من المرضى بتوعنا او العملاء بتوعنا بيحتاجوها.
بصر 30 لا امسح 30 مثلا. انا دافع بس انا.
دكتورة أمينة كان عندك سؤال.
Okay, thank you, Dr. Stephen, for staying with us. We are very glad to have you here and to host you to talk with us in non-formal ways, such as the ACT and the process-based therapy are always, they are not a classic presentation and then we just ask. So I was wondering, and I am a psychiatrist, I'm a physician, and I came from a very biological school of teaching. I studied in Ain Shams University in Egypt, and they are heavy into biological psychiatry. And I was reading through your article that was published just before the book, comparing the CBT and ACT. And then I was going through your book and wondering in my mind, how would you answer people that say, we need a diagnosis. Every patient has to have a diagnosis. We manage since diagnosis. So this is a very tough conversation, I would assume. So how do you respond to this claim or this assumption or this attitude when you meet?
And do you need to translate the question before I answer?
I think Dr. Hala will translate it as a whole.
As a whole, I will translate as a whole. Okay.
Okay. The purpose of diagnosis is to determine the needs of the individual patient. And a good diagnosis leads you to an understanding of etiology, course, and response to treatment. What people say we need a diagnosis, they are saying now we need a diagnosis inside the traditional normative categories that we've been using, which are a very ill-fitting suit. In the STAR-D trial of major depression with 3,700 patients, there were nearly 1,100 different combinations of signs and symptoms. If you ask how many people had a combination that was so unusual, only one 1/100% shared them, and the answer was more than half. In any area of medicine, you would no longer call that a specific thing that you're treating. And in every other area of medicine and of healthcare, when you have a situation like that, you need to go more personal. Personalized medicine is everywhere. And we know we can't just say, oh, you have cancer. That is such a crude category. We won't know how to intervene. And if I can add just a little bit, and then I'll pause and finish, but it isn't just that these things are mental health only. People have needs in behavioral health. How do I engage in health practices? How do I step up to the challenges of physical disease? In social wellness, your relationships and the quality of your life. So when you think of the whole person, when you put them in these top-down normative categories that are very ill-fitting suits and don't predict the individual trajectories of human lives, you no longer are treating the individual client with what they really need. And so, to my mind, yes to diagnosis, yes to case conceptualization, but no to normative categories put atop people that don't fit their needs. We have to do better. And in other areas of medicine, when we've hit this situation, we've gone back to the lab, we've got more personal, and we figured out how to actually target. That's exactly what we need to do in mental and behavioral health.
Thank you.
Can I translate, Reza, please? Can I translate? دكتورة أمينة كانت بتسأل بروفيسور ستيفن هايس على الناس اللي بيجوا العيادة وبيبقوا مصرين إنهم ياخدوا دايجنوزس أو ياخدوا اليافطة بتاعة التشخيص. الناس دول نعمل معاهم ايه؟ فهو كان بيرد عليها بيقول ان مهما كان العيان محتاج ان هو يتحط له دايجنوزس، احنا كنا زمان بنقسم العيانين لفئات او كاتيجوريز، فبيبقوا محبوسين في ستراكشر ضيق جدا. فلو وجدنا في العيان اي اعراض من مرض تاني، يعني مثلا ما فيش عيان تلاقيه اكتئاب صرف او anxiety لوحده، يعني قلق لوحده، لازم بتلاقي فيه بعض الأعراض من أمراض مختلفة. وهنا وجدوا إن إحنا محتاجين نفصل العلاج على العيان، على احتياجات العيان، لأن كل عيان بيبقى احتياجاته مختلفة. مفيش one size fit all، يعني ما ينفعش ناخد مقاس واحد ينفع لكل الناس. وبيقول ان الكلام ده مش بس في السايكاتري، مش بس في الحاله الصحه العقليه، ولكن بينطبق على كل مجالات الميديسن. ان مثلا ما فيش بروجرام واحد لعلاج الاورام، ما فيش بروجرام واحد لعلاج الضغط، لا، في كذا دواء وكذا نوع من الادويه، وده ينفع لفلان ما ينفعش لفلان. فكل الدنيا دلوقتي بتحاول انها تدخل على الانديفيدواليز، او ان هي يبقى علاج متفصل على العميل ده اللي بيغذي احتياجاته. وكمان بيتكلم على ان كل انسان محتاج ان هو عنده behavioral needs، يعني سلوكيات محتاجه تتغير، اللي هي بتدخل في اللايف ستايل. ايه السلوكيات اللي لو غذاها او لو بقى انفولد فيها زي الصحه مثلا بتحسن حياته. شكرا.
Okay. So my next question, or asking for more advice, what is the best model to conduct supervision in ACT? Like DBT do a team consultation, and it has a very detailed how to manage the team consultation meeting. I personally have an opinion that people learn more when they learn from experience, not by reading books or attending a course. We have been conducting the peer supervision meeting every other week for a year and 3 months now. And some people come to me and ask me personally to have an individual supervision where I am a senior supervision going through their cases. So in your experience, what is the best model to have supervision or to share the experience?
Yeah. Let me answer that question in a broader way first, which is, what is the best way to learn ACT? And what even is ACT when you think about what you really need to learn? I think the best sequence, or the ones that I've done with my students, is that you need to explore these processes yourself. And I think that generally is first. Enough discussion to have that make sense, but then to dive in. That when you can connect with these processes more from your heart, then you need to begin to work on your hands and your head. You need to understand the principles and the skills. But you will always be less able to see with your clients if you're all by yourself than if you're part of a community, a supportive group, because sometimes people outside the room can see things you can't see inside the room. So what is the skill that you need to learn? How to read these flexibility processes in your clients, how to embody them yourself, not as some great and grand example of psychological flexibility. No, that's not what I mean. Ask my wife. I'm still working on it. I've been working for 40 years. I have a long way to go. But that you know they're of importance, and you're willing to constantly learn and challenge yourself, and to bring that into the room with your client, so that you read the processes, you embody the processes, you target the processes with kernels that can work, but you always do it in a way that the betweenness between yourself and the client itself reflects those processes. So if you ever find yourself wanting to say to a client, you shouldn't be so fused, just put tape over your mouth and say nothing, because you're not going to produce a more cognitive, flexible space by criticism and judgment. You're going to have the exact opposite effect. And so from it, toward it, with it. And what supervision does is to help you see these places where the model can break down. And so first with heart, then with head and hands, with the books and the workshops, but then supervision is where it really gets real, because practice in those elements, it's just, it requires practice and feedback.
Yes.
Yes. Yes.
Luckily for
Can I
the
translate?
Arab world we have
Can I translate?
طيب
Okay.
أول حاجة بعد كده we have in Egypt and we in the Arabic world we're starting this peer supervision, and we'll be going for a year and a half now, and we have lots of followers, and we did so much good. We saw that our performance, our combined performance has increased together through this peer supervision. It's a process.
Absolutely. And I know we need to translate, but absolutely, we're better in groups. And we can talk about how to run these supervision groups if you want to get into it, but there's really good models there, the Portland psychotherapy model and so forth. But maybe you can translate what I answered.
Thank you. دكتورة أمينة كانت بتسأل بروفيسور ستيفن عن أفضل موديل أو أفضل نموذج للإشراف الأقران في الإشراف في مدرسة الأكت. فهو دخل في إجابة متعمقة جدا إزاي البني آدم مننا يدخل في الأكت من الأول خالص. فكان بيتكلم على الأول أحسن حاجة إن إحنا نستكشف الأكت الأول من بره ونفهمه كويس، نهضمه ويدخل قلبنا الأول ونفهمه بالحواس بتاعتنا، وبعدين نمارسه على نفسنا ونتناقش فيه مع بعض كزملاء، وبعدين نغطس فيه to dive in. واهم حاجه ان هو تعرف الهارت بتاع الاكت اللي هو الجوهر بتاعه، مش بس التكنيكس، كمان حضور السبورتيف جروبس في الاخر بقى هو ده اللي بيبلور المساله، لان هو بيقول ان مجموعات الاشراف بتوريك اللي انت مش شايفه زي ما احنا بنعمل في الجروب بتاعنا. بعد كده السكيلز ان احنا الاول ازاي نقرا النموذج المرونه النفسيه في العيانه اللي قدامنا، وازاي ان احنا نلبسه احنا نفسنا ازاي ان هو يبقى ممزوج جوانا، وبعدين هل ان احنا عندنا القابليه او الويلنجنس ان احنا نفضل نتعلم لغايه الاند اوف اور لايف، لان هو بيقول انا بقالي 40 سنه بتعلم القصه دهيت ولسه عندي لونج جيرني تو جو، يعني العلم لا ينتهي، وان انا استحضر الروح بتاعه او الجوهر بتاع الاكت في غرفه العلاج، لان الموضوع رايح جاي ما بينك وبين العميل وما بين العميل وبينك. وبيقول ان اهم حاجه لما انت تكون في غرفه العلاج اوعى تقول للعيان you shouldn't be fused too much، يعني ما تبقاش ملتحم قوي بافكارك لهذه الدرجه، لان انت ساعتها بالظبط بتبقى حطيت ليبل على العيان وعملت جادجمنت وبقيت بتحط نقد كتير، فده عكس خالص الروح بتاعه الاكت، فساعتها حط بلاستر على بقك وما تتكلمش. والسوبرفيجن هو بيخلي بيرسخ بيسري العلاقه ما بيننا كمعالجين، وبيورينا اللي احنا مش شايفينه لما بنبقى في الجلسه العلاجيه لما بنحطها في الاشراف. شكرا.
So for my next question, let's dive into the process-based therapy. So it's been very intriguing for us to learn about it. So if you can maybe summarize process-based therapy in a few sentences or so. What is it? Why it is so special?
Process-based therapy is not a new form of therapy. It's a new way of thinking about what evidence-based therapy should look like. And when I say new, for an ACT person, and a CVS person more generally, it's very familiar ground, because ACT has had a very unusual course of development over 40 years. For the first 20 years, really, it was process focused, developing RFT, psychological flexibility model, measures, working even on our philosophical assumptions so we can do this hard work, kernels. But the more traditional protocols for syndromes approach that evidence-based therapy was pursuing was very different in development. Now, ACT, uses randomized trials focused on disorders, in part because that is how we get to talk to the mainstream of the healthcare system. But the real vision is to individualize to the person based on their needs and what they're doing, and to try to get to the smallest set of processes that do the most things. And the psychological flexibility model, which can be expanded and needs to be added to, I can maybe even say a few things that need to be added. But what you learn in ACT, turns out, is at the basis, at the core of what process-based therapy is, which is simply this: take the individual in all their complexity, think of them as a whole human being, think of them in terms of their underlying biophysiological processes, their health practices, diet, sleep, exercise, their genetic history, all of that. Think of them in terms of their social, cultural level, and their families, their groups, their religious beliefs, and so on. And then think about them in terms of all of the aspects of their psychology, and try to identify the processes that are creating an interaction of all those elements that is leading to the problem or inhibiting the prosperity that you seek. I don't think we should only be focused on problems. We are focused also on promoting prosperity, in my opinion. Health is the goal, not simply removal of a latent disease. And so when you think in that way, evidence-based therapy becomes what core biopsychosocial processes are of importance with this person that needs to be targeted and changed in order to help the client reach their goals. And it turns out you can use the psychological flexibility model to do 70, 80% of that work without even much expansion. That I can show you the data here. There's new studies coming out that will, but so PBT is simply asking evidence-based therapy, all therapies, what are the core processes you're targeting with this individual and why? And can you show that you can deal with all these levels and dimensions and how they fit together to serve the needs of the individual? Don't just put them into a category and treat them as an error term. Every voice needs to be heard. Every human being needs to be taken seriously. And so if there's 1,100 different kinds of major depression in 3,700 people, like in the STAR-D trial of major depression, you have to stop just saying, oh, you have major depression. It doesn't tell you what to do. You need to know, what does that person need? So that's what PBT, and to my way is, and I think basically ACT has always been a form of PBT. We just didn't have that way of speaking, but we have it now so that we can open up the door and say, we're not interested in making everybody ACT therapists, but we are interested in taking the processes we're learning about and having you use them And if there's others that you know about that are very important, show us the data because we want to use them. And that to me is a way of breaking down the walls between all these traditions. Let's get the whole world and all these different wings on the same page and keep our eye on what we're trying to do, which is to improve human well-being.
دكتورة هالة.
كان سؤال مهم من دكتور فادي بيقول ايه هو العلاج المبني على العمليات المعرفية او العمليات اللي موجودة داخل العيان بشكل عام يعني. فدكتور ستيفن تفضل وقال ان هو مش علاج جديد ولكن هو طريقة جديدة للتفكير، بداية من أطر العلاقات، نظرية أطر العلاقات، ونزولا إلى العلاج بالتقبل والالتزام، واللي هو بيتضمن الهكسافليكس أو السايكولوجيكال فلكسبيليتي موديل اللي هو النموذج المرونة النفسية اللي كلنا عارفينه، والتقاء بالعمليات اللي هي السلوكية السياقية، العلوم السياقية السلوكية، وكمان دخلوا في ميتا اناليسيز لكل الابحاث، عملوا اناليسيز للابحاث كلها علشان يطلعوا الايفيدنس، علشان احنا بنشتغل ايفيدنس بيزد ميديسن او ايفيدنس بيزد ثيرابي. فايه اللي بالظبط من الحاجات اللي اتعملت فيما مضى من الابحاث وكانت افكتيف في حياه العيانين. والمقصود بالبروسيس بيزد ثيرابي هنا ان هو هيعمل خطه مفصله لكل عيان على حسب احتياجاته هو الشخصيه، وان محتاجين ان نموذج المرونه النفسيه يعني يتسع الى عمليات اخرى في العلاج المبني على العمليات اللي احنا بنتكلم فيه. وقال ان الكومبلكسيتي بتاعت او التعقيد اللي في البني ادمين، التعقيد في حياه البشر لا يمكن اختزاله ابدا في ان احنا نقول ده فلان ديبريشن او فلان عنده انكزايتي او كذا. لا، الموضوع معقد جدا عن كده. لازم ناخد بالنا كل عيان عنده ايه في حياته هو اللي معطله، ونتارجت الحته اللي متعطله دهيت. ولفت النظر الى النظريه اللي كنا بنتكلم فيها قبل كده اللي هي البايو سايكو سوشيال موديل، وقال ان البروسيس بيزد ثيرابي بيركز على كل ما هو بيولوجي في داخل العيان وعلاقته بالكالتشر والسوشيال لايف اللي عنده، وعلاقته بالعوامل او الاحداث التراجكتوريز اللي بتحصل في حياته وكيف تؤثر عليه وعلى السلوك بتاعته. فكل ده الاسبكت بتاعتنا. فالبروسيس ليد تو بروبلم سولفينج، يعني المفروض ان احنا نركز على العطله اللي موجوده في العيان مش الليبل اللي بنسمي العيان بيه، ونوصل في النهايه الى المرونه اللي تخلي فيه تنوع وتخلي العيان ده يعرف يمشي في حياته. ونتارجت البروسيس اللي محتاجه تشينج، مش ما يبقاش فيه مانوال واحد لكل العيانين. قال عباره حلوه جدا، قال every voice need to be heard، يعني احنا محتاجين نسمع كل البني ادمين، يعني ما فيش حاجه اسمها انت فلان ديبريشن تروح مع الناس الديبريشن كلهم، لا، كل بني ادم له سبيسيفيك زي بصمه الصباع، it's not a matter of categories. ولازم نتوقف على ان احنا نقول فلان عنده ميجر ديبريشن، ولكن نقول له هيعمل ايه في الديبريشن ده، يعني هو طب هعمل ايه فيه، هو ده المهم. شكرا.
I'm at a place where would you be okay if I do about 10 minutes and describe some data that supports what I just said?
Yes,
please.
Well, I'm going to share some slides with you then, and I will stop periodically and you can translate as we go. I won't be very long. Don't let me do a half an hour talk, but I do want to share.
You have all the time. We are here with you and you have all the time. And the Friday is like Sunday in the Western countries. So we have, most of us are free today, I would assume.
You have no idea how dangerous it is what you just said. You're giving me a microphone and you're saying you have all the time. You are in big trouble.
I trust you. I trust you, and we are very, very happy.
Well, 2 hours from now, you may regret it.
No, no.
Let me share this screen and see. Do you see a thing that says, what are the processes that empower?
Yes.
Yes,
Yes.
we can.
Okay. So we decided if we're going to go on this journey, and we mean it, that everybody can participate. The ACT people, the CBT people, the humanists, the psychoanalysts, the existentialists, everybody. Do you have good ideas? Do you have data? Okay, let's find out. And so we decided to look at every study on psychotherapy or any other psychosocial intervention. We didn't do medications, but every psychosocial intervention in a randomized trial with a psychosocial outcome having to do with mental and behavioral health. And that they claimed that they had done a proper mediational analysis to determine the process of change. And we fought to get the entire world's literature, not just in English, every study we could find in every language ever done in the history of the world that was properly set up. And we looked at almost 55,000 studies, myself, Stefan Hoffman, Joe Sorochi, and our students and colleagues, 50 students for 2.5 years. And I can show you what we know. This stopped as of 2018 because it took us 2.5 years to do it. So there's the very, very new data. But I'm going to show you, and what I'm going to show you is only measures that are replicated at least once. Because sometimes people go back and they say, oh, here's the process. If I take one item from here, one item from there, and I'm thinking, you did this after the fact. You didn't do this predictively. That's, we don't want to, have things we can't replicate. So it has to be replicated at least once. And that led us to around 300 statistically correct studies that we can draw from. I'm going to show you that. It's under review. It's going to come out in Behavior Research and Therapy. It's in a revise and resubmit, but I'm certain it's going to be accepted. And you'll be able to see it in a few months. But I'm going to show you the data. Maybe you could translate here and then I'll show you the data.
اوكي دكتور ستيفن كان بيتكلم على الابحاث اللي ادت الى انهم يطلعوا البروسيسز او العمليات العلاجيه اللي بتؤدي الى تحسن العيان، فدرسوا 54,633 ستاديز بكل اللغات، يعني ما خدوش الانجليش بس، لا خدوا كل اللغات، وكمان 73 ريبليكيتد ستاديز، يعني تم تداول نفس الداتا في او نفس النتائج اتكررت في كذا بيبر يعني، و281 statistically correct analysis، يعني حطوها في analysis قويه جدا بحيث ان اي حاجه ادت الى نجاح التغير في العمليات اللي داخل العيان وتؤدي الى تحسنه حطوها. يعني كل الحاجات اللي هتطلع في الريزلتس دي هي الحاجات الايفيدنس بيزد اللي هي بتؤدي الى نجاح العمليه العلاجيه.
Okay. So these are the kind of findings we have. You probably can't read very well, but I'm just saying, for example, things like the AAQ and psychological flexibility, or the 5-factor mindfulness scale and mindfulness, and so on down the road. Over here is how many findings. So I'm going to show you is how many findings in these different categories were in those nearly 300 studies that properly assessed processes of change in the entire world's literature for any psychological intervention. So we're not just looking at CBT studies, ACT studies, any study. And here are the results. Maybe you can translate that part, and then I'll do a drum roll.
درسوا كل حاجة أثرت في حياة العيان وخلته يتحسن، زي الموديل بتاع المرونة النفسية اللي احنا كلنا عارفينه، زي اليقظة الذهنية أو التعقل، زي ازاي نعمل ريستراكشرنج للأفكار اللي هي المعطوبة اللي في دماغ العيان أو اللي بتطلع له بشكل دائم. واشتغلوا على كمان الانكزايتي سنسيتيفيتي، ازاي ان هم يقللوا السنسيتيفيتي للانكزايتي والفير علشان يحسنوا حياة العيان.
This is everything that we know using the best accepted way of knowing what processes of change are, just expressed in terms of the percentage of replicated findings. And you can give a scan here, psychological flexibility other than mindfulness, dysfunctional thoughts, anxiety, sensitivity, and so forth. And these are the percentages. If you could just quickly translate that, I'll go to the next slide.
هنا الدكتور بيبين لنا بعد ما اتعملت الإحصائيات، وجدوا ان اول 4 أو 5 فاكتورز اللي مكتوبين قدامنا دول، اللي هي المرونة النفسية واليقظة الذهنية وتغيير الافكار المعطوبة او المعطلة، وازاي ان احنا نعمل تنظيم للمشاعر زي الانكزايتي والفير، والحاجات اللي بتزود الكفاءة النفسية، وتغيير البيرانتنج او اساليب الوالدية في العائلة. دول اكتر الحاجات اللي ممكن تحسن حياة العيان.
Dr. Steven, people are asking if this is in a published study, so they...
Yes, as I said, it's in a revise and resubmit at Behavior Research and Therapy. And it was an invited article. Michelle Krast, the editor, invited it. So I'm sure it will be accepted. I'm working on the revision right now. It has to be submitted in the next month. And so I expect it will be available within 3 months. But you get to see it here. You can read about it within 3 months there. But do you want to translate that, or is that okay?
دكتور بيقول ان الدراسة دي هتتفنش وتتنشر بعد 3 شهور، تقدروا تقروا عنها، اللي هي شملت كل الميتا اناليسيس دي.
Now I just want to look at these are percentages of the findings with, I don't know if you can read, it's a little small, ranked in terms of top to bottom. Psychological flexibility is at the top, then mindfulness, and so on. Now, if I just do this, combine things that obviously, if you're an ACT person, you'd say, oh my goodness, that's so close to psychological flexibility concepts. Of course, we start there, but then mindfulness is already the 4, open and aware pillars of the hexagon model. Anxiety sensitivity is an early idea, very similar. It leads to like experiential avoidance, being afraid of and avoiding anxiety. Self-compassion, very, very similar, correlates with psychological flexibility measures 0.7 or above. Self-compassion is very, very close. Decentering is another way of speaking about diffusion and distancing, behavioral activation. So what I'm doing here is saying nobody would, well, very few ACT people would say, well, this, let me say this. Most people familiar with the ACT model would say these easily can be brought in. Now, I think many of these others can be brought in, but just a little bit of a conversation. Self-efficacy. If you have a values-based choice and you're committed and you're saying, I'm doing this, your self-efficacy scores are going to go up. Yes, I can do this, but I'm not being grabby here. I'm not saying, oh, it's all ACT. I'm just saying, just take the obvious ones. And now I'm going to show you the results when you combine these. maybe you can translate that to explain the checks.
اوكي دكتور ستيفن بيقول انت لو بصيت للنموذج ده مكتوب فيه كل الحاجات اللي بتأثر جيدا في حياة العيان، وجيت تحط علامات عليها عشان تقول مين اللي فيهم يتماشى مع مدرسة الأكت، هتلاقي ان معظم الحاجات احنا بنعملها في وسط العملية العلاجية بتاعة الأكت. بس هو حب ان هو يتواضع شوية، فبيقول ان انا مش هلمهم كلهم في الأكت، ولكن بطريقه او باخرى احنا بنطبقهم في الاكت، زي السايكولوجيكال فليكسبيليتي، المايندفولنس، الانكزايتي سنسيتيفيتي، ازاي ان انت تمنع الاكسبيرينشال افويدنس او التجنب الخبراتي، ان انت ازاي تجد براح داخلك للمشاعر القلق والانكزايتي وتعيش معاها وتعمل اللي انت عاوزه. كمان السيلف كومباشن جزء لا يتجزأ من الاوبزرفنج سيلف، ويعني موجود انتجريتد في كل الارياز بتاعه السايكولوجيكال فليكسبيليتي. كمان بيقول الديسنترنج ده اللي هو زي قريب من فك الاندماج مع الافكار، ان احنا ناخد ديستانس شويه من الافكار بتاعتنا. والبيهيفيرال اكتيفيشن طبعا يدخل في الكوميتد اكشن، هو الحته بتاعت السيلف افيكاسي او اللي هي الكفاءه الذاتيه. وكمان لو بصينا السيلف استيم ممكن نقول بدل السيلف از كونتنت نقول السيلف از كونسبت كونتكست، يعني الذات كسياق، فده بيتسع لكثير من الاشياء.
So when you do that, here's what you get. This is the percentages. 55% of all findings are obviously part of the ACT model. But when I go beyond things like parenting, social support, the therapeutic alliance, there's nothing in there that we would feel uncomfortable about. I'll give you an example of the therapeutic alliance. Just translate that part. Well, no, wait a minute. No, don't do that. Let me explain this. You'll have to translate it in a clearer way than I'm saying it. But when we add, let's say things like parenting, social support, the interpersonal skills, the therapeutic alliance, which I'll talk about in a second. And then yes, of course, being entangled in rumination or worry or negative thoughts. Health practices, diet, sleep, exercise, moderation in drinking, self-efficacy, I've already mentioned. And then there's a few little things at the end, maybe they don't fit so well, but there's nothing in the main things we know about that an ACT person with just a little bit of flexibility can't say, yes, I have good ideas about how to target those processes. So when you go in a process-based direction, you suddenly find that there's many friends that you need to talk to who have different theoretical ideas. They don't know that they're your friends, but you don't have to feel threatened by all these different schools and so forth. Let's find out what we really know about how to empower people and build our models around that. We have an idea about how to do that with the EAM and so forth, but sorry for the challenge to the translator. I know this is a little, but see if you can do a simplified version of that.
دكتور ستيفن بيقول ان السايكولوجيكال فلكسبيليتي تعتبر زي ما تكون هي الفيل اللي جوه العمليه العلاجيه، يعني هو اهم حاجه. صح ماشي، ولكن في فريندز تانيين او اصدقاء تانيين احنا لو اغفلناهم ممكن العمليه العلاجيه ما تكونش كامله، زي مثلا البيرنتنج او الاساليب الوالديه او الدعم الاجتماعي او العلاقه العلاجيه اللي هي اللي ما بينك وبين العيان، دي ليها جزء كبير قوي. ولو اغفلتها مهما تعمل في قصه المرونه النفسيه العيان لا هيسمعك ولا هينفذ اللي انت بتقول عليه لو العلاقه العلاجيه مش اوكي. كمان قصه النيجاتيف ثوتس او الرومينيشن، الافكار الكتير اللي بتتكرر، زي ما كان حد من زمايلنا سأل في جروب الاشراف، الافكار اللي بتتكرر كتير دي محتاجه ان احنا نشتغل عليها شويه، مش بس ان احنا نعمل فك اندماجي يعني. وكمان اللايف ستايل والاكسرسايز والدايت والتوسط في الحياه وعدم شرب الكحوليات او التقليل منها، كل دي من الحاجات الاصدقاء لينا، فما ينفعش ان احنا نغفلهم. واي حاجه يعني البروسيس بيزد ثيرابي بيقول اي حاجه تخدمنا هناخدها، يعني ما عندناش مشكله ان هي تكون بره بره النموذج بتاع المرونه النفسيه او الهيكسا فليكس، بس هناخدها وتخدمنا في البروسيس بيزد ثيرابي. I wish I could do.
Thank you so much. Just a few more slides. You look at this, you may have seen it before. We're now at 900 randomized trials. By next year or late this year, we'll be at 1,000. There's a new randomized trial every 3 days. And we're proud of that. I'm proud of that. But really, this period, 20 years, when the ACT book came out in 1999, we had 4 randomized trials. 4. And it isn't that we're lazy. We were working hard. We were working hard on what? On the processes and on the measures and on the components and on the underlying basic principles in relational frame theory. And so now the reason we're the process elephant, a very small part of evidence-based therapy, ACT is a small part, but a big part of what we know about processes of change is because we invested those many years of obscurity in a long-range vision of the smallest set of processes that do the most good in the most areas for the most people. And then when you look at the randomized trials and you see, oh, so many different areas, of course, that's by design. We were not trying to treat a syndrome. We were trying to empower people. And when you empower people, they naturally have things they want from you. And some people want to win a gold medal at the Olympics. And there's ACT coaches who have helped people do that. I know the coaches, I saw the matches, I saw the gold medals. I know where it came from. If you were, unable to sleep, or if you're entangled in pornography, or if you're dealing with cancer, I mean, you look at all these things. Some of them are aspirational. Some of them are clearly things that would be in the DSM. To me, that's a different evidence of our role in humanity. We as mental and behavioral health specialists are here to empower people, and every voice matters. So if we go in the process direction, now the technologies go everywhere. And how is that bad for us in our role in society? To me, it's a very good thing. And I'll share only 2 more slides, but maybe you could translate those. I'll try to follow you as best I can.
Can you bring the previous slide, please?
Yeah, I just did.
اوكي. دكتور ستيفن بيقول ان هو ابتدى مع زملائه في الاكت علشان يعملوا يبلوروا مدرسه الاكت من اول سنه 86 لغايه سنه 2004، وكانوا بيمشوا بتقدة وخطوة ثابتة علشان يحطوا بالظبط ايه اللي يتحط في نموذج المرونة النفسية. ووجد ان هو من بعد سنة 2004 حصل جامب كبير قوي في الابحاث اللي اتعملت على الاكت، وده كان فخر كبير لان الناس بدأت تعرف النموذج وتبدأ تتعامل بيه. وهو طول الرحلة بتاعته هو فخور ان هو وصل للعمليات اللي بتؤدي الى تحسين الهيومانيتي او تحسين الحياه بتاعت العيان واللي بتديله قوه او empowering him. next slide please. وخلال هذه الفتره طلعت ابحاث كتير في كل المجالات اللي حضراتكم شايفينها دي، بما فيها امراض عضويه وامراض نفسيه، وحتى الكوتشنج، يعني حتى المدربين اللي هم الكوتشز ابتدوا ياخدوا من البروسيس دي ويحطوها في الحاجات علشان الناس تاخد اولمبياد وتقدر انها تخرج من البورنوجرافي مثلا، اللي هي الافلام الاباحيه، او ان هو يخرج من القمار او السبستنس ابيوز او اي حاجه. Thank you.
And what does that do for us if we go in this direction? Well, for one thing, when we need to help people who are facing extreme challenges where the outcomes could be anything. For example, the wars we're going through, what's going on in Ukraine, or what's going on in the Horn of Africa. And, you know, when the World Health Organization said we need to do something because the South Sudanese refugees in Uganda, you know, came with nothing except the clothing on their backs and their lives. And we knew it was going to go in every possible direction. They came to us, this very small part of the evidence-based therapy world, because they knew it wouldn't just be depression or anxiety that resulted. It would be relationships breaking down. It would be anger and violence. It will be sleep problems. It will be, you know, everything you can imagine. And so when they called me, I said, I referred them to Russ Harris. He's a better popularizer than I am. And Russ created this very nice cartoon book and an audio tape, which is now in 21 different languages, including, of course, your own. And look at what the World Health Organization says now after 5 randomized trials. They say something that I would be embarrassed to say. This is for anyone who experiences stress wherever they live and whatever their circumstances. Because those trials showed if you give a little bit of act done by healthcare workers or not even professionals necessarily and as psychotherapists, in group settings, at follow-up, the development of mental illness was reduced by 50%. 50% with a cartoon book and an audio tape. And if you already had a mental health disorder, the impact was as great as self-help in the developed world with people of privilege. And so my point being, when you go in a process direction, now we've become of relevance to the world in a way that we haven't been. They think of the psychotherapists way at the end. We need to be thought about at the beginning. But we need to be able to step forward and say, here's what you can do to prevent, to help, to assist. And right now, this is being used in the Ukraine. ACBS just gave, due to an anonymous donor, free participation in the conference for anyone who is working with war refugees. And so we're stepping forward because we took a process focus. Places like the World Health Organization knew they needed us. And turns out our ideas delivered. I'll show 2 more slides, but maybe you can translate that part.
Okay. دكتور ستيفن بيتكلم على البوكلت الصغير اللي احنا كنا حاطيناه على الجروب بتاع روس هاريس، اللي كان فيه بيتكلم على ايه اللي ينفع في اوقات الازمات، خاصة في الناس اللاجئين او الناس اللي في الحروب زي اوكرانيا واوغندا. وطبعا هو دكتور ستيفن مش فوكسد قوي على الارياز بتاعتنا زي سوريا والعراق وليبيا وكل الاماكن المنكوبه وفلسطين، فأي عيان من هناك بيعاني من قلق أو أرق في النوم أو اكتئاب أو علاقات انتهت بمأساة، سواء لأن القريب أو ده اتخطف، أو إن هو غرق في مركب هجرة، أو إن هو مثلا اتقتل. فكل الأمور دهيت درسوا إيه الإيفيدنس اللي يخلي حياة العيانين دي تتحسن بمقدار 50% بحاجه جنرال خالص، يعني مش متفصله عليهم كانديفيدوالز، لانهم مش هيقدروا يجيبوا ثيرابيست يكفي كل الناس دي. فعملوا البوكلت ده عباره عن صور كرتون، وكمان معاه شريط تسجيل بمختلف اللغات بتاعه الاماكن المنكوبه، بحيث ان هم لما يستخدموا البوكلت ده ومعاه الكرتون يقدروا معاه الاوديو، بيقدروا ان هم يخرجوا من الاسترس ولو بشكل مؤقت او بشكل بسيط، لغايه لما ياخدوا الرعايه اللازمه يعني. فهو ده بيبقى موجه للناس المنكوبين او الناس في اوقات الازمات. وبيقول ان السايكوثيرابيست بدل ما زمان كان بيتحط في الاند اوف ذا سبيكترم، ان هي بعد ما يستنفذوا كل الحاجات يروحوا في الاخر للمعالج النفسي، لا، هو عايز ان احنا نقدم نفسنا في الفرونت كناس تقدر تعمل تشينج او تقدر تعمل تغيير بسبل بسيطه وحاجه جنرال تخدم الناس كلها.
The other thing that it gives us is that each cultural group can take these processes and fit them to their culture. And so you see this explosion across the world in different languages. But this is also from the ACBS website, just the list, which is very long, of the number of studies that have done things like tried to fit ACT processes to Islam. And not simply by even using metaphors or stories from the Holy Quran, which is good, but no, actually sometimes I'm adding elements or features or emphases that would only occur to people in that cultural group. And this is not just Islam. When you go to Japan, when you go to China, the same thing happens, because the ACT model doesn't say, these are the values. No, they say, what are your values? And then we listen, yeah, person by person. And we don't take a superficial answer. We have methods for digging in, to getting beyond the defense. Oh, I don't care about anything. I don't want love in my life. I've only had pain when all those things people do to limit their lives. ACT helps us move through that, and we can fit what we're doing to the individual, but the individual is in a cultural context. I can't make these modifications. I can read the Holy Quran, but I can't fully understand it like a person raised in a Muslim home. So they have to be done locally. One reason why this conversation is important, why I spend so much time speaking to chapters around the world, is to say, we need you. And the we is the whole world, because you will learn things in modifying and fitting the basic principles and processes to the particularities of your cultural and community. And the whole world benefits when you do that. The whole world benefits. So translate that, and I'll do one more slide.
اوكي. دكتور ستيفن بيتكلم على ان احنا بنطبق بقى الحاجات اللي احنا اتعلمناها دي على كل الثقافات، بس في نفس الوقت احنا بنشوف اللي يناسب الثقافة بتاعتنا من الاكت علشان يقدر يشملها. اتكلم على الاسلام كديانة منتشرة في الشرق الاوسط، بس هو ما يعرفش ان احنا كمان الكريستيانيتي منتشرة في الشرق الاوسط. فبيتكلم على ان الميتافورز او الامثلة اللي ممكن نقولها للعيان في الكالتشر بتاعتنا، مثلا ممكن نجيبها من القرآن، ممكن نجيبها من الكتاب المقدس. كل واحد على حسب ديانته. وكمان بيقول ان الاكت ما بيقولكش ايه الفاليوز، يعني ممكن في اليابان انت يبقى عندك قيم معينه، في مصر يبقى عندك قيم معينه، في السعوديه كذا كذا، ولكن هو بيسالك انت ايه الفاليوز بتاعتك، ايه اللي يهمك انت. فبيتكلم على العيان اللي هو بيقول له انا مش بهتم بالحب، وانا بهتم بس الوجع اللي عندي ده اخلص منه. فبيدخل كمان في الاكت انت بتدخل جوه كمان مع العيان، تتعمق معاه لغايه ما تطلع الفاليوز من جواه، مش انت اللي بتفرضها عليه ايا يكن يعني. وبيبص الحاجات اللي بتعطل العيان نفسه وبيعمل لها انليميت، يعني بيخليه يخرج للبراح الواسع بدل ما كان زانق نفسه في كورنر. والانديفيدوال ان كالتشرال كونتكست عشان يعني يشوف الانديفيدوال في الثقافه اللي هو فيها، وينشر ده في كل الورلد على حسب كل واحد على حسب الثقافه بتاعته.
And the final slide is saying, when you do this pathway, even though we never really wanted to play the protocols for syndromes game, eventually the data gets so gigantic that even on all the various bodies, the World Health Organization or the Centers for Disease Control, or the in the United Kingdom, the National Institute for Health and Care Excellence, the so-called NICE group, and so on. When you go through and look now, I'm answering really Amina's first question to me. And you say, well, where's the evidence that it's good for major depression? We have that evidence. Panic disorder, we have that. OCD, we have that evidence. But when the person is in front of you, you know, being able to fill out the forms and you do the DSM diagnosis, it doesn't tell you what to do with this individual really, but okay, we do it. But when you get that human being in front of you, now you can apply all of what you know about processes of change across all these levels and these dimensions psychologically. And the psychological flexibility model expanded a little bit. ACT methods expanded a little bit. Openness to all traditions. You can be a more effective therapist, and you can be a change agent for your culture and community in areas that they don't even look to psychotherapists to give good answers. And that's new in the world. What it's prideful, please forgive me. I'm an old man, I got a little bit of this. But what we've done has never been done before. We are sitting here with something for the world community that they don't even yet realize what's now here. That we actually have a simplifying process as to how to focus on the smallest set of processes that does the most good in the most areas. And when that really lands, you're going to see this happening in your religious meetings, in your school meetings, in your organizational meetings, when your team gets together in your clinic. These processes apply everywhere to all of us, all the time. And whether it's called ACT or not, why would we care about that? It's fine to learn about ACT and so forth, but this isn't not building castles in the sky or pyramids with, you know, plaques that say, see this and be afraid. And they have a hard time even knowing who that person was who built that pyramid. All these things will pass away. But what will not pass away is the good that we can do for others if we can put things into the human culture. And so the vision here is not how to act uber alles. It's not how to make everybody act people. It's how to put processes into the hearts, heads, and hands of people that uplift them and empower them. And yes, deal with syndromes. It's okay. if we have to do it that way. Eventually, I think this will pass away and we will see a more individualized precision medicine, we could say it that way, that has happened in many other areas of mature healthcare. And I think that's where we're headed in psychiatry and psychology and the mental health professions.
Can I
Go ahead.
translate, Professor? I will translate, okay?
Yes, please.
Okay. بيقول إن العلاج بالتقبل والالتزام هو أحسن حاجة بتنفع مع الناس اللي عندهم كذا disorder. يعني الكوموربيديتي زي ما دكتورة أمينة كانت سألت في أول اللقاء إن الناس يعني مش مهم قوي اليافطة قد ما مهم إن إحنا نساعد العيان ده إن هو يخرج من اللي هو فيه ويتغير. وقال فكرة إن اللي قدامك اللي قاعد قدامك في غرفة العلاج مش اكتئاب وطلع له بني آدم، هو بني آدم وعنده اكتئاب، فأنت محتاج تساعد البني آدم مش تساعد الاكتئاب. وقال ان طول ما احنا بنشتغل بالفلكسبيليتي موديل نقدر نزود عليه من كل المدارس الاخرى، نقدر نزود عليه اللي ينفع مع العيان بتاعنا. وبيقول انا رغم ان انا كبرت في السن ودي حاجه تاتش مي بصراحه، يعني بيقول انا اللي اتعمل ده ما اتعملش قبل كده ابدا، ان احنا نشوف العمليات الدقيقه اللي بتحصل في داخل العيان واللي بتسبب ان لو صلحتها بتسبب تشينج كبير في حياته، ده موديل يعني ما اتقالش قبل كده في التاريخ خالص. بيتكلم ان دي تنفع في كل المجالات ولينا كلنا سواء عيانين او مش عيانين وات اني تايم وفي اي مكان في العالم. يعني ممكن الاكت ده يستخدم مع اي بني ادم واي بشر، حتى طلبه المدارس، طلبه الجامعات، الناس اللي في الشغل عشان تحسن الاداء وكذا. وكمان بيدي مثال، يعني انا لو بني ادم بنيت هرم ومت، انا مت واحنا هنموت وكلنا هنموت، بس ايه اللي هيتبقى من الهرم؟ ما هذا البناء اللي انا مش هستفيد منه. بينما انا لو غيرت في حياة البني ادمين ده هيستمر حتى بعد ما انا اموت وانتوا تموتوا وكلنا نموت. فحاجة انت فعلتها في قلب العيان وفي دماغه واديت له تولز عشان ينفذها بايديه في حياته اليوميه، هي دي اللي هتبقى وهي دي اللي هتستمر حتى بعد ما احنا نموت. Professor, I have a question.
Yes.
Regarding the mediators for change and the nodes for the process-based therapy, which node you will choose in the beginning of the treatment in order to make change in the whole process?
That's a very good question. And I think we need new ways of thinking of case conceptualization to really answer that well. So far, we know that in the psychological flexibility model, all of the processes matter, and they all need to be strong for any one of them to do their full good. It's like 6 sides of a box, and if any one side is absent or weak, or 2 sides or 3 sides, it's no longer a box, and it won't function like a. So we need to think of the whole and all the processes. But the question about how to intervene, so far in group designs, randomized trials, we've not yet seen a big difference in sequence. But I know that's not true at the individual level. And here comes the biggest change of all, that we're just beginning, which is that we are going to have to create new measures and analytic methods to fully implement the process vision. And I can explain what they are and say just a little bit about what's coming. Some of this is published now, so you can read and get a sense of where it's going. But maybe I'll pause there and you can translate it, and then I'll give you an example.
Okay.
I have a small question also,
أنا
but
كنت بسأل دكتور ستيفن عن لما احنا بنعمل البروسيس. Yes. لما بنقول البروسيس بيزد ثيرابي ونرسم الحياه بتاعه العيان في المربعات اللي احنا كنا خدناها في المحاضره لما شرحتها لكم، فبقول له ايه الجزء اللي هتهتم بيه انك تبتدي علشان تعمل تشينج في حياه العيان. فهو بيقول ان السيكونس مش هو اللي مهم البيجيننج، بس قال كمان ان انا مش محتاجه ان انا اشتغل على الهول بيكتشر عن طريق البروسيسز الصغيره، وبيقول ان فيما هو قادم يعني في الابحاث القادمه هيعرفوا ايه اللي يفعل البروسيس ككل.
Okay. I had a small question, Professor.
Oh, can I finish this question? Okay, so there's a new study two new studies. Both of them are published in the Journal of Contextual Behavioral Science. So if you are a member, and if you're not, you should be, join the chapter, but yes, join the mothership. It's only $12. If even that's too much, email the director and ask for a scholarship. We don't let money be a barrier.
Yes.
But if you look in JCBS, was one on the process-based assessment tool. It came out about 5 months ago. And then there's a brand new one on idionomic analysis. And here's what we do. We take flexibility items that are designed with a broad perspective, a process-based perspective. We take them frequently in the client along with outcomes. And then we look within the individual. For that individual, what predicts the problem? We don't average. We treat the individual as a person who needs to be heard, not turned into an error term. And then the statistics look to see if you're similar to other people, and we'll use that information, but only if it helps you see the individual more. So it turns statistics on its head. The individual is now the sacrosanct level, and the group is the possible error term. But we will look at the group as long as it helps us see. It's like, now I can see a little better. Now I can't see so well. So let me show you an actual human being analyzed that way. And I'll put in the chat stream the link to the article. I'll probably even upload the article if I can do it during the translation, so I won't waste time. And maybe you could translate that, and I'll show you an actual human being and see how it answers the question that you're asking, Hala.
اوكي. دكتور ستيفن بيقول ان البروسيس في بحثين جداد اتنشروا، وهيحط لنا لينك بتاع بحث منهم على البروسيس بيزد اسسمنت تول. دي تول علشان تبين البروسيسز اللي عطلانه في العيان. وقال لك ان احنا كنا بنعمل الابحاث الاول على الايتمز اللي موجوده في اللي هو الايموشنال الفلكسبيليتي سايكولوجيكال فلكسبيليتي، ونشتغل على الايتمز كلها بتاعت السايكولوجيكال فلكسبيليتي لغايه ما نطلع اوتكم، والاوتكم ده هو اللي بيساعدنا نعرف ايه اللي حسن العيان. هو بيقول دلوقتي المهم في الابحاث ان احنا نركز على الانديفيدوال مش على الجروب. صح هنبص على الجروب وكل حاجه، ولكن الانديفيدوال هو اللي بقى مهم علشان نقول ايه اللي هيساعد الانديفيدوال ده، بس في نفس الطريق بنبص على الجروب.
So what you're seeing here is an individual human being who is unusually burdened by struggles with sadness. You would say they're depressed, but I'm trying to avoid that way of talking. I want to focus on what the person actually knows. They're distressed by and entangled with sadness. The open-headed arrows are negative relationships. The closed-headed arrows are positive ones. I'll skip for now the dotted lines. This is one individual. What builds greater and greater sadness? Maybe you could just say that much, and now I'll unpack this network.
اوكي.
We could translate that.
الدكتور هنا بيبين لنا الدايره اللي موجوده في حياه الانسان بيشعر بالحزن، فهو بيقول ان السهم اللي متخطط بالاسود ده هو الحاجات النيجاتيف او الحاجات اللي هي بتؤثر بالسلب على الحزن بتاع العيان ده هو. والحاجات الإيجابية اللي هي الحاجات اللي هو بيعملها علشان يتواصل مع الآخرين، دي هتحسن الحزن بتاعه شوية، وإن هو ما عندهوش تحديات في الوقت الحالي، فده بيقلل الحزن شوية.
When this person is entangled with sadness, they stop doing things to connect to other people. When they stop doing things to connect to other people, they begin to feel they have no meaningful challenges. When they begin to feel they have no meaningful challenges, they space out and they struggle to connect to their present moment. When they space out and struggle to connect to their moment, they feel more entangled in sadness. This is a self-amplifying loop. This is one form of what we call depression. And anyone hearing me who has any ACT training at all, or even any clinical training at all, would have good ideas about where to intervene with this person. There's several, but there's not an infinite number. It's a small set. When the person's sad, could we help them reach out and connect with others? When they're feeling as if there's no meaningful challenges, could they come over here? Where here choosing to do what's personally important is not linked to what is a meaningful challenge for them. They lose contact with their values. And when that happens, they feel more stuck, unable to change. Sadness produces that stuckness. But what you would want to do, if I can get in contact with people, is to also bring my values into that. For example, if there's values for intimacy, relationship, caring, support, compassion, and so on. And when I start feeling spaced out, can I use methods to help me come into the present as a whole human being, as a spiritual, conscious, aware human being? Because when I do that, those kinds of mindfulness, so-called methods, it's going to help with this entanglement with sadness. So here we have 1, 2, 3 easy entries that are obvious for this individual. Now, when you say with depression, where should we start? Should it be mindfulness? Should it be value? I say, no, we should start with the individual. Depression didn't walk in the door. That person walked in the door. Don't let our categories turn people into error terms. Let our categories, like these here, help us see the individual. That's worth doing, but not if it blurs the person. And so the solution to the answer to your question is we're going to have to give you new measurement tools, new analytic tools. I'm now working really hard. For 2 years, I've been working on this, on turning all of this into an app that will be free. How quick I can get it into Arabic, I do not know, but it will come, and it's going to be in beta before the end of this year. We're not very far away where you could have a free app and your clients will tell you what they need, because they will tell you what their lives are like in process-based terms. And when we're there, we will have an alternative diagnostic system essentially, because we will have a new way empirically of saying what the individual need is when a person is struggling with mental or behavioral health problems.
Can I translate? Okay. واحد من النماذج بتاعة المريض اللي جاي باكتئاب إن هو يشعر بالوحدة. فمن الأفضل إن إحنا نبتدي بإن هو ريكونكت مع الأذرز، أو إن هو يبتدي يتواصل مع الآخرين. لما هو يجي يتواصل مع الآخرين هيقول لك أنا مش شايف معنى في إن أنا أتواصل مع الآخرين. فيجي نرجع نراجع منظومه القيم بتاعته. هل هو مهتم بالكيرنج فور اذرز؟ هل هو مهتم بالتراحم بينه وبين الاخرين، بالتواصل مع الاخرين؟ ساعه لما يجي يتواصل مع الاخرين ويشعر ان هو ديستنت او ان هو مش حاضر في اللقاء، ساعتها هنستحضر المهارات بتاعه اليقظه هنا والان، وازاي ان هو يعمل ارساء لنفسه في المكان، وازاي ان هو يتواصل مع الاخرين وينتراكت مع الاخرين. ده هيرفع الحزن بتاعه، هيرفع الدبس بتاع الدبريشن، هيبقى احسن. فمن هنا هو بيقول ان اللي هيساعدنا فيما بعد ان شاء الله لما الامور تتقدم شويه في الابحاث اللي الدكتور ستيفن بيعملها، ان هو عايز يعمل اب، هيعمل اب على الموبايل تدخل عليه تعرف بالظبط ايه البروسيسز اللي عندك معطوبه، علشان هي دي اللي هتبقى الاحتياجات بتاعتك اللي انت محتاج تشتغل عليها مع الطبيب بتاعك او مع المعالج بتاعك. وبيقول عليها نيو اناليتيك تول او النيو بروسيس بيزد اسسمنت تول. ومن هنا هيصدر بعد كده تشخيصات بديله او دايجنوزيس الترناتيف سيستم مختلف خالص للتشخيصات. يعني مثلا العيان ده محتاج يشتغل على السيلف استيم، العيان ده محتاج يشتغل على الفاليوز، العيان ده محتاج يشتغل على الافيكاسي، وهكذا.
So I put in the chat stream the actual articles.
Yes.
Thank
One
you.
of them I think is well, they're both done with Word versions rather than from JCBS. If you want the real kind of article version, everybody, if you are a member, go to JCBS. It's free.
Yes. Yes.
We're motivated now.
Okay. So let's receive some questions from the audience. I hope we can answer most of these questions. Some were answered in the stream as we talk. From an anonymous attendee, he wanted to read more and deeply about the philosophical basis of ACT and how ACT see life, personal role, and capability in life. So there is any recommendation for reading or things that would be attended?
Yes, if you're wanting to dive deeper into the philosophy, the initial start in, they're a little expensive, these books, but there's the Wiley book on contextual behavioral science, the Handbook of Contextual Behavioral Science, that has a good section on the philosophical work. I will put an article in the chat stream, an early article, but there's a good book also called Varieties of Scientific Contextualism, which shows how ACT fits into a broad range of philosophical approaches that are contextualistic. And it's published by New Harbinger Publications. Let's see, there was one more, but my aging brain is slipping away. Maybe it'll occur to me. But let me say also that if your English is pretty good, or you're willing to do Google Translate with all of the problems that brings, there's a philosophy special interest group in ACBS that is very good. But I think the philosophy part is important, because when people come into therapy, they're often thinking of words as literal truths. And they're struggling with that because they're taking everything this mind gives them, good, bad, and indifferent, and they're treating it literally. And that means it's very easy to program people with the media or with critical people or parenting that wasn't adequate and so forth. When you can step back and notice and allow thoughts to be used as tools, it's much, much easier. Well, what is the philosophy that treats even our own concepts, like psychological flexibility, that same way? Well, the contextualists do that because they don't ontologize, turn into things concepts. They don't say this concept is true because it corresponds with that thing out there. They're always being humble and saying, well, from my perspective or point of view, this way of thinking is helpful, and never taking that next step, which most scientists do, of the reason it's helpful is that it's literally true. Once you do that, learning new things, finding places where your concepts are wrong are very difficult scientifically, for the therapist, and for the client. That's part of why they're a client. So it helps when you know the philosophy, because the philosophy is in the treatment. And it's a very friendly philosophy to many cultures and point of view. So it has translated well once you link contextualism and pragmatism to values-based goals. And that last piece is something we did that wasn't in pragmatism. I mean, maybe I could give you an article in the chat stream on that too. We early on broke away from the hermeneuticists and the social constructionists and all that. They're contextualists, but the pragmatists were sometimes very vague about what their goals are. And when you do that, stepping back can just produce a cacophony. And the same with clients. We don't want people to treat their own thoughts and feelings as if they don't mean anything. No, they mean important things. But first, what are your values? What do you really deeply care about? Now I can evaluate whether thoughts are helpful or not. And from that place, I can say, well, respectfully, mind, I'm not going to give you more attention on that thought. Thank you very much for trying to help me, but I think this is more helpful, without having to get into an arm wrestling match with your mind. So the philosophy is hugely useful to you clinically. And I very much appreciate this question, because I think while it's initially hard, it will lift up your ACT work. And I'm pleased. Yeah, I'm doing a talk to the Persian chapter, specifically on self as context, making sense of spirituality, and this underlying philosophy, because I think it will open some doors if you take the time to learn it and know what functional contextualism really means. It's not crude pragmatism. It's not what feels good is true. It's nothing like that. It's more like living a values-based life is the point.
I ask a question, please, Dr. Stephen, how much time we have?
Oh, that's a good question. You can set the limits.
Yes.
I will take a peek at my schedule, but I think I have no limits. I told you this is a very bad idea. You told me time is
We
not
are
a
so
problem.
happy.
Now
We
you're
are
going to
so
have to
happy.
suffer.
Okay, I will
That's not a
translate,
suffering. That's something we enjoy.
until you review your I will translate. دكتور كان في سؤال بيتكلم على الفلسفه اللي ورا الاكت او اللي ورا البروسيس بيزد ثيرابي، ازاي نقرا فيها. فقال على كتابين، كتاب عن دار وايلي اللي هي الفيلوسوفي اوف كونتكستوال بيهيفيرال ساينس، وفرايتيز ان بيهيفيرال كونتكستواليزم من نيو هاربنجر، والفيلوسوفي انترستد جروبس على الاي سي بي اس في فيلوسوفي انترستد جروبس. بعد كده كان بيتكلم على ان العيان بيجي غرفه العلاج بيسال على الليترال تروث او الحقيقه المطلقه، واحنا ما عندناش حقيقه مطلقه. حتى اللي احنا بنحاول نفهمه للعيان انه يرجع خطوه لورا ويشوف مشاعره وافكاره من بعيد، مش عشان ما يهتمش بافكاره ومشاعره، بالعكس هي الحاجات دي بتشاور على حاجات مهمه، بس ايه اللي من الحاجات دي يخدم منظومه القيم بتاعته، هي دي اللي ههتم بيها. والحاجات اللي مش بتخدم منظومه القيم بتاعتي بمنتهى الاحترام هقول لدماغي شكرا، وهقول والله دي مش هيلبفول بالنسبه لي، فانا مش ههتم بيها في الوقت الحالي. وده اللي هيخدم حياه العيان. ديب انسايد ايه اللي انت بتهتم بيه، هو ده اللي بيبقى الفاليوز بتاعتك، مش البراجماتيزم ان احنا حقائق ثابته، مفيش حاجه ثابته. كمان الكونسبت اللي انت بتعتنقها النهارده ممكن بكره تكتشف ان هي خاطئه، او ان هي ظهر نظريات جديده. وكذلك الحال بالنسبه للمعالج، لازم يبقى عنده التواضع بتاع العلماء اللي زي دكتور ستيفن كده، ان هو يقول والله انا من وجهه نظري شايف ان كذا كذا كذا، ويبقى عندك استعداد ان ممكن لو وجهه نظرك دي طلعت انها مش صائبه انك تقول اي ام سوري، يعني او تقول انا غيرت رايي. دكتوره امينه.
اوكي، احنا هنسمع سؤال من المجموعه، فانا هسمح للناس ان هم يتكلموا فلغايه لما هم يردوا على الاسئله بتاعتنا او يتعلموا، يعني يدخلوا في الكلام معانا. اوكي، دكتور ستيفن Muruj want to ask about, is there any place that you recommend us for taking a trustworthy courses about the topic? She did not specify process-based or ACT, but I would assume ACT more.
Did you say for taking courses? Is that what you're saying?
She's asking about the courses.
Okay. Well, I have a conflict of interest warning. If I mention courses where I'm teaching, I make money from these things. You know, if you can handle the English, I think the best online course out there, I'm sorry to say it that way because it's my course, but I worked for 2 years on it, is ACT Immersion. And then after that, it was designed as a 1-2 ACT in practice. They're a little expensive. If you find that you cannot afford them, ask for a scholarship and go through a process. And we have a very flexible thing. If you're wanting to see that first one, just go to ACT.courses. ACT.courses. Or you can go to the company that produces them, Praxis Continuing Education and Training. So their link is PRAXISCET. Russ Harris also has very good courses, and there's others out there, so I don't want to be grabby, but I will say that I know, because I know how hard it was, that the videography and the structure and the so forth, I believe, is world-class. When we did the ACT Immersion course, I filmed it in Hollywood with 20 staff using Hollywood union videographers and audio people. You would not want to know what that costs. I mean, it is deep into 6 figures, but it's been what it means is when I'm working with a client, you can see the twitching of their eyelid. I mean, so I'm very proud of those courses, and I think you'll find that they are very useful. I know it sounds like a commercial, but I put a lot of my life into them because I know I'm not going to live forever, and I wanted to give my best and let others carry it forward from there. So I would refer you, and Praxis then has quite a number of really good people, but also Russ and others. There's many things out there. And of course, but the translations are coming. And already in this course, you can click on it and get Portuguese or Spanish, and so with enough encouragement and interest, I'm sure we could add Arabic to the list. It's difficult because you have to have staff support then to answer the questions and so forth. So it's a big commitment for the company, but can I answer this in a way that's not just commercial? I want to go back to how to learn ACT. Can I just make it more concrete? If you're just starting, I would say get out of your mind into your life or the happiness trap and work on yourself a little bit. Then get a simple ACT book that just gets you oriented. Russ has ACT Made Simple. I have a very simple book with the American Psychological Association called Acceptance and Commitment Therapy. There's different options. Then, as you begin to get more serious, get Learning ACT. And that's will walk you through the processes, the second edition. That's New Harbinger publishes that one. Then get the original ACT book in its second edition by Guilford Press. Why? Because that starts getting into the meatier issues of philosophy and theory. If you need a broad orientation before you do that, A Liberated Mind will work. And that's one you can give to family and so forth. A self-help book you can't give to family sometimes. It feels like you're telling them there's something wrong with them. But that book you can. And that's why I wrote it. Tells the whole science story. And after that, take the populations you work with and get really good kind of protocol oriented, how to do it oriented books that walk you through. All of those books then put into workshops if you can afford it, or can find good trainers to help you with, and peer support and supervision with those in your care system. If you do that, you will end up being pretty good. Now, people ask, why isn't there certification? Why don't you get a diploma? Well, each of these steps, you can get a certificate saying you've done it, but we don't do that because as soon as we say you are anointed as a therapist in ACT, it means there's a big hierarchy. The people doing the anointing and everybody else. And money starts changing hands. You just look, that's the way it works. Who's on the top of the hierarchy? Founders, the people who, what happens when they get old? What happens when new ideas come? They have to approve. What happens when they die? The disciples have to approve. This is not a good place for science to end up. When I looked at the trajectory of this, and I almost did this, well, let's certify therapists, but I looked a little careful early on. I said, I don't like where this is taking us. This is taking us in grabby, me directions, and it'll corrupt our. So instead of that, we have a recognized trainer system. And I hope a whole number of you, if you really care about wanting to be part of the ACBS community, seek that status if you want to be a trainer. And how much money changes hands? Less than the cost of processing the paperwork. Other recognized trainers will work to create competitors because we're not in it for the money. So recognized trainers is one step. And then the second one is competency. And we are developing competency exams in ACT Immersion, ACT and Practice. At the end, I have competency exams. I've published on that, new demonstrations of how to assess. And what you assess is your ability to read, target, and change processes. That's competence. It's not following a technique, not doing it by the book or doing it the way the founder did it. No, you do it the way your personality, your approach leads you to do it, as long as it moves the processes and is held to account for that. So what I showed you here of individual measures of processes, if you think about it, what it is feedback for your competency. Because when you target them, you can then look to see, did my client change in the process I targeted? And so we're going to solve training by, I know this is going to be impossible to translate, I'm sorry. We're going to solve training not by hierarchy and anointings, but by empowerment and holding ourselves to account for doing a better and better job of targeting psychological flexibility. And I still have things to learn. So don't put me in the top of the hill. There's better ACT therapists than me. And I'm trying to get better. And if we all do that, we will get better.
دكتور ستيفن بيقول ان مفيش حاجه اسمها licensed therapist للاكت، لان هو مش عايز يبقى علشان هو الفاوندر يبقى هو اللي approving اللايسنس ثيرابيست. فبيقول ان الافضل ان الناس تاخد كورسات، وان بيقول ان في الكورسات بتاعته ان في الاخر competency exam، يعني انت تشوف ان انت competent، ان انت عملت كل العمليات العلاجيه وتقدر تعملها بنجاح من خلال الكالتشر بتاعتك، بدون ما يكون هو بيتدخل في الجزئيه دي من الداخل يعني. فانت بتاخد السيرتيفيكت بتاعه الكورس بتاعتك وبتحضر السوبرفيجن وهكذا، لكن هو مش عايز يبقى هو اللي ابروفنج الثيرابيست، لان هو بيقول لو انا مت طيب هنجيب مين يابروف وهكذا. فانا حاسه ان هي يعني اتاتشدني بصراحه.
Okay, for people raising hands, I had allowed you to talk if you want to ask question. الناس اللي رفعوا ايديها وانا سامحه بالكلام لو حابين تسالوا سؤال مباشره. There is a question from Dr. Basma Tolba or Ms. Basma Tolba about how to join your research team.
Well, you already have. Not in the sense of my lab. My lab is going away. I will be out of the university in 1 year, but I will be working very hard. I'm president now of a 45-year-old charitable organization that will be producing this app I talked about. And I'm working with teams around the world. So what I would suggest, if you really care about the research, is to work with your chapter members to create research nodules. It's hard to do good research with one person. You need a team. Create the teams. And in the chapters that really work well, that begins to happen. And you get a group of academics and researchers and practitioners and providers of all these different settings. And then the spirit that's in ACT and in CBS of mutual support starts working. And that's why we're getting a new randomized trial every 3 days. Now, I try on my newsletter to give clarity about where I'm going. And I post pretty often to the listservs in ACBS. I don't do Facebook so much. I find it distracts me too much. I'm too old for that. Never mind Instagram. Oh, please. So I will put a link in the chat about how to get on my newsletter list. And I would encourage you to, if you want to be part of the research team, think about it broader than just this old man. But even if it's just about what I'm doing, follow my newsletter, look at these articles, but then work with the international community. But start with your own, start with the people in your chapter and in your setting. And there are good academics there producing research. And can I say, you know, Iran is a pretty amazing example. And, you know, Egypt has such a rich tradition. And I've created problems by naming our country. As I go through each country, you know, you have academic centers of excellence and knowledge in the Arab world that can be centers of change worldwide if we can find a way to build these partnerships. And that's the best way to do it, because my bandwidth individually, it's very small. I'm too old, I get tired, but working together as a community, you know, we have the capacity to change the world. We already have. And we're just getting started, but we are just getting started. So it's a very good question. And I hope you can join me on that part of the journey, because I think research is critical. It's not the only way to learn. We shouldn't be so arrogant as with our science hat on. We learn by clinical experience, by life experience, by our wisdom traditions, by our culture. I mean, we're not the first persons on the planet. So we learn by our ancestors and by our cultural traditions. But science has proven itself to be progressive in a way that, you know, the artists and musicians and so forth can't quite be progressive, even though they speak with the deepest wisdom that we can imagine. And by the way, they almost always say things that are very acty. If you've not noticed that the great novelists or poets or movie makers or musicians know something about psychological flexibility, then I don't think you're looking closely. So, but we have something to add special as professionals and as scientists. So thank you for the question.
السؤال كان عن ازاي نلتحق بالمجموعه البحثيه بتاعه الدكتور ستيفن هايس. فهو بيقول بكل تواضع ان هو في خلال سنه هيسيب الجامعه، بس اللي عايز يتابع النيوزليتر بتاعته ممكن يتواصل معاه ان هو يبقى يعرف الاخبار بتاعته اول باول. وبيقول بمنتهى التواضع ان محتاجين ان احنا في كل دوله ان احنا نعمل مجموعه بحثيه، لان مفيش باحث بيشتغل لوحده. وبيقول ان الابحاث مش هي الطريقه الوحيده للتعلم، لا احنا بنتعلم من القراءات بتاعتنا، من الكورسات، بنتعلم من الممارسه الاكلينيكيه مع العيانين، وممكن نتعلم كمان من خبرات الاخرين ومن الحكمه اللي خدناها من الناس القدماء بتوعنا يعني.
Amina?
A flood of questions and the time to embrace all of these
Connection.
especially that there is self as a context, and I think we need more meetings that, like you mentioned with the Persian chapter, that are focused talk on certain aspect. I understand that this is our first meeting and we had lots and lots of questions, and we want to learn from you and from your experience. So I will be greedy and would ask for more meetings like the Persian chapter.
Yes. We would be deeply honored.
Yeah, I do try to say yes, but I do try to space out and to distribute because the demands are great and the bandwidth is limited. So what I've asked actually is that for people to consider, yeah, of course, there's the Steve Hayes, but there's also such a large number of very experienced and well-trained and progressive people. Once you get into the CBS world. And so don't let, there's a form of ego that goes into group ego. You know, the ego goes me, I'm important. The group ego goes, we're only treated seriously if these very small number of people are spending the time because they're the best known. And that's not healthy. I mean, you can think about this. Peer supervision groups. Peer supervision groups means people who know less than you do about ACT and you're learning can teach you about ACT. It's true. It's true. If I'm in one of those with the beginning graduate student, they sometimes see things that I didn't see. So let's, I'm not saying this to say, don't ask the old man to do anything. I'm saying this to say, use me when I'm really needed. I'll try to be there when I'm really needed. But also, let's take on the responsibility of saying, this is a group effort that will last generations and is not narrowly focused on ACT. It's focused on creating a behavioral science more worthy of the challenge of the human condition. That's the motto of ACBS as its goal. And so the same processes that we work on with ourselves and with our clients, we should work on with our groups and consider the voices within that will lift you up. You have beginning leaders in your community who should be raised up and you should be listening to them. Yeah, I may be looking at some of them right now. You have people around the world who would absolutely do a free workshop or so us working together, you know, and that's why I push ACBS. It's not because it's a castle in the sky. It's because we're better in groups than we are as individuals. We're better. So ask of me what you need, but if you really also are listening to what I'm saying, make sure that you are maximizing, not in an ego way, but in an effectiveness way, your ability to get what you need, but also to create what is, and to put into the world community things that are not there. That's the other part. It isn't just learning from others and even yourselves. It's contributing to others, becoming a recognized trainer, getting in the conversation, doing the research, and changing the world for the better.
Professor Stephen, we can't thank you enough. Today was amazing. Like we are mind blowing. Yes.
دكتور فادي الحتة دي لازم تترجم معلش. دكتور ستيفن
has to translate the last part because it's mind blowing.
دكتور ستيفن كانت الدكتورة أمينة بتسأله إن هو ممكن يعمل لنا ويبينارز تانية، فهو بمنتهى التواضع بيقول أنا أتمنى ولكن أنا لازم أوزع العطاء بتاعي على جروبات كتير، فبيعتذر ان هو ممكن ما يبقاش افيلبل في الاوقات القريبه يعني، ولكن بيقول حاجه مهمه قوي احنا يعني بالنسبه للقيم هي مهمه قوي بالنسبه لنا. بيقول ان انتوا تتعلموا من الناس الاصغر منكم كمان، يعني ما تفكرش في الايجو قوي، يعني ما تفكرش في نفسك قوي ان انت بقى خلاص الاستاذ العظيم بتاع الاكت، لا انت طول الوقت بتتعلم من الترينيز بتوعك. يعني العمليه ongoing رايح جاي، وبيقول ان الجروب سوبرفيجن مهم جدا جدا عشان نتعلم من بعض. في حاجه انا ما بقاش شايفها انت شايفها وهكذا. ده بصراحه في منتهى التواضع يعني.
So maybe, friends, that would be a good place to end. I know there's things I put in
Yes.
the chat stream
Thank
that
you.
not everybody got. So please, organizers, distribute them. You got them. And if you didn't, you can email me. And also, I hope you'll pull a transcript of the recording as well as the recording. And the slides and so forth are all fine there. But so that everybody, if you know, you wanted to see the literal translation of what I was saying, that would be a kindness. I know it's a burden, but I hope you're able to do that. It would be a kindness to the people to be able to see the tape with an actual transcript again, if the English was a little challenging.
It's a pleasure. It's our value to help others. We will kindly do it. We'll be honored to this. So we have to thank everyone. We had like hundreds of people today, and Dr. Stephen, thank you so much for today. Today was really amazing, and I wish you could read the comments. There are like, people are really in so much happiness for today. So this is so much. Actually, there are some people here attending with me now who want to say hi. Also.
Oh, sure.
Yes. Okay.
Absolutely. I'm happy to see the group, see the groups.
Hello. Hi.
Ah, yes. Thank you so much for spending time with me. Much appreciated. And thank you to the organizers for the opportunity to speak to the Arabic community in this way.
Thank you. Thank you so much.
Thank you so much. Thank you.
For more events to come at some point. At a good place.
At some point.
At some point. Thank you. Good night.
Bye.
Peace, love, and life. My best.
Bye bye.
شكرا لكل الناس اللي اشتركت معانا النهارده، وبنعتذر لو في اسئله ما لحقناش نرد عليها. اكيد هنحاول نرد على كل اسئلتكم. احنا عندنا عده حاجات. عندنا الافيليت بتاعتنا على السي بي اس، وموقع السي بي اس ده باشتراك وعليه حاجات كتيره جدا من اللي ذكرها دكتور ستيفن. في المجموعه بتاعتنا على الفيسبوك، وهي اللي فيها بنتداول الحاجات باللغه العربيه والمترجمه، وبيبقى فيها اسئله وطروح ومناقشات مختلفه، اسمها العلاج بالتقبل والالتزام اكت. وفي مجموعه الواتساب دي خاصه باشراف الاقران، ودي ليها شروط للانضمام. يعني مش اي حد بيبقى بينضم معانا، لان هي بتبقى فيها مناقشه حالات وبنتجمع وفيها مشاركه. يعني برضو للي حابب يعني يبقى عايز ينضم. دي كل الحاجات، ودكتور ستيفن شاركنا ببعض اللينكات. انا هحط اللينك بتاع التسجيل بتاعنا النهارده very soon. ما اعتقدش اليوم، لان انا بالنسبه لي كده انا يومي خلصان. فهشاركه على المجموعه، هشاركه على مجموعه الواتساب، واللي اشترك في ايميل هيجيله اللينك بحيث ان هو ينزل المحاضره بالترانسكريبت بتاع الشات. يعني الشات اللي اتكتب كله هيبقى ظاهر له، يقدر يعني يقراه باللينكات اللي كانت موجوده. وشكرا جدا جدا لكل اللي اشتركوا معانا.
عايزه بس اقول اللي عايز يشترك في جروب تمام، اللي عايز يشترك في جروب الواتس ويكون براكتسنج الاكت فعلا، يبعت لي ايميل. انا كتبت الايميل بتاعي hala_sayyah@hotmail.com علشان يعني اعرف اذا كان اخذ شهادات في الاكت ولا لا، واقدر ان انا احطه على جروب الواتس. واشكركم جدا للنهارده بجد. يعني شكرا دكتور فادي، بجد كانت فرصه هايله هايله هايله. انا عايزه اقول والله وعملوها الرجاله بقى وبتاع.
ده مجهود لينا كلنا. ودكتوره هاله، يعني النهارده كنت نجمه اليوم بجد. يعني الترجمه بتاعتك كنت مظبوط على طول، وبجد الناس مبسوطه جدا. يعني من غيرك اليوم هيكمل بامانه. يعني سو جود. يعني دكتوره امينه، بجد انا مبسوط بالجروب بتاعنا، ومبسوط كل الحضور بتوع النهارده، الناس اللي حضروا معانا فيزيكال واللي معانا فيرتشوال برضه. شكرا لكم كلكم بجد. يعني
شكرا لكم يا جماعه. الحد اللي كان كاتب باسم البوست وبعت السؤال اكتر من مره وقال ان محدش جاوبني على اسئلتي، وكان بعت السؤال مرتين. هو كان السؤال: هل الاكت هو البروسيس بيز ثيرابي يعد الفورس ويف فهو دكتور ستيفن شرح ده early بقى، شرحه بدري قوي وقالوا فان هو ايه يعني هل هو علاج جديد ولا هو حاجه مختلفه عن الاكت. ففي التسجيل لما تسمعوه هتلاقوا الشرح ده اتقال بدري جدا، يمكن اول ربع ساعه كان بيتكلم في الموضوع ده. فمع يعني السؤال تم اجابته، ما تقلقوش. ميرسي.
عايزين التسجيل ده في كل حته بقى يا دكتوره امين.
حاضر، من عينيا.
شكرا، مع
العفو.
السلامه.
مع السلامه.